I would wish for an extra day in between Saturday and Sunday. Or just an extra day, like an extra hour within the day specifically for a nap. Like, sure, and Skinny, you don't think it's a
Good afternoon, everyone. We will begin here shortly. If you are a committee member who is on the phone, if you would unmute and let us know that you are here. We do have a couple of items that are being voted on today, so we do want to make sure that we know you are in attendance. So again, if you are a committee member on the phone, if you will just come off of mute and let me know that you are here. We should get started here in just a few moments. Rachel, I'm still gathering up to see if we've got a quorum.
This is Joe from AARP.
Hey, this is Daryl Hershaft with Take Care Utah.
Sorry, I don't know if anyone can hear me, but I'm having technical difficulties, so just give me a second, or Dr. Britton, if you're on, if you want to start while I try and figure out what's going on.
Yeah, so Rachel, I can hear you, so maybe we'll just give a minute. Okay, we do have a quorum, just a bare minimum quorum today. So I don't know, Rachel, if you want to go, or if you want Dr. Brenton to start the meeting. So do we have Dr. Brenton? Are you on?
Yes, I am here.
Okay.
I just can't, Sharon, I can't pull up the thing in my screen. I can't do the two screens at once right now. So what we want to welcome everyone to our meeting today for the MAC meeting. Thank you for being here. And our first order of business, would it be to do the minutes from last time, or what's the first order there? Sorry, I will soon be able to pull up both on this screens. I just am not where I can get both screens up right now.
Yeah, no problem. Yes, the first item is to approve the meeting minutes from June.
All right, do we have a motion to approve the meeting minutes from last month?
I think I'm working now, so I'll make the motion
great.
to approve the minutes.
Okay, so guys.
I will second that.
Great. Well, I will pass it on to you, Rachel. Thank you.
Thank you. Okay, and then sorry about that. I got a new computer like a couple weeks ago, and I'm still trying to assimilate. Perfect. Thank you, Dr. Britton, for taking care of that for me. We'd also like to thank Carlos Flores for his service to the MAC. As some of you know, Carlos recently became a therapist. He just doesn't have the time. So that being said, we do have 2 open appointments for consumer representatives for Medicaid recipients. So if you know of anyone who has been a I think preferably current, but also past member of Medicaid, or is a caregiver of someone that currently receives Medicaid, please let them know that we're looking for people to join the MAC. I believe we're also still looking for people to join the BAC as well. And we do need some folks, I think, to be on both still. Sharon, correct me if I'm wrong there.
Yes, that is correct. If any current MAC members want to serve on the Beneficiary Advisory Council, please reach out to me. Thank you.
Perfect. And I believe we have flyers for the MAC. I think those can be sent out again if they haven't already. But please try and recruit where you can. I know that not everyone has the time these days, but I think the consumer voice is one of the ones that frequently we don't always have here, and I would personally like to have here. So for our second point, we are voting. Right, we are going to take a vote to change the time for the MAC meetings. And the reason for this is that it overlaps with the Behavioral Health Commission, which means that a lot of folks that join this meeting can't be here for the whole time. And it also means that MAC members can't be at the Behavioral Health Commission either. Before we take a vote on this, does anyone have any thoughts about this time change, or does this time change not work for them? Hearing no concerns, does anyone want to, is that something?
Sorry, Rachel, I just had to activate my microphone. I will not be able to attend after 4, and so I don't know if that's a problem, if we need to find another pharmacy representative, if that's the case.
I would, if the vote goes through, I would think that would probably mean that. I think you probably, yeah, I think that would be the case, yes. Otherwise, you'd only be here for half the meeting, and that wouldn't be so great, I don't think. Anyone else have any concerns about that change, or does that eliminate them from being able to actually serve on the MAC? Okay, hearing no other comments, does anyone want to make a motion to change the time of the MAC from 2 to 4, or from 2 to 4 to 3 to 5?
This is Brian. I can make that motion. I may have to leave just like 5-10 minutes early, but I think that can be accommodated. So I can move that we move that meeting to 3 to 5.
Does anyone want to second that? Or like, if this is, I mean, I know that some people don't work till 5 every day, and some people immediately have conflicts at 5. So going right up until 5 or even over 5, that could be bad. So if no one wants to second this, I mean, we can possibly, Sharon, correct me if I'm wrong, go back and see if there's a better time. Like, I don't want to have everyone dropping off at 4:30 or 4:45, or having like we have to find completely new MAC members to work with this time change. Sharon, I don't know if we have any other options of times. I know like everyone's schedule at the state is very packed.
Yes, that is true. Everyone's schedules are packed, and there's never going to be one time that fits everybody, right? I mean, we could take this back. I could send out a survey of, and try to get people's, can they really make the 3 to 5 for the entire time, or give a suggestion of a better time, or I could give suggestions of better times and they can vote on it. I mean, I'd have to work with Jennifer Strohecker on coming up with some good times that would work. But I mean, we can do that if you guys are not prepared to make the vote today to change the time. And I don't know if others from the state want to chime in on this time change, but there are options, right? We can make those happen.
Hey, Bridget, can you again tell us what the conflicting meeting is? You say it's at 4 o'clock, or no? Yeah, it's at 4 o'clock.
From 1 to 3, it's the Behavioral Health Commission, correct? I think
Okay.
I'm right. I don't want to, I could be wrong.
So even a 2:30 to 4:30 wouldn't work. Okay. Maybe I need to kind of retract my motion and then let's have Sharon look at some times that might be better. And then maybe we can come back next meeting and relook at that.
Is that okay with everyone? I suspect that this time change might not be great for everyone. If I'm being completely honest, it isn't awesome for me. It would not be great. I do have a usual running commitment at 5 on Thursday, which means that I would have to either push that back or like be on the road at the end of the MAC meeting, which is something I'm not particularly psyched about. So yeah, Sharon, maybe we send out a survey about if this time really does work for folks and if there's like maybe a better time. I'll just say it doesn't work well for me, but I wasn't going to let my personal stuff get in the way of everyone else's work. But it doesn't sound like this is great for everyone. Is that okay, Sharon?
Yes, absolutely. I will do that. And we will get back to you and we'll bring it back in the October meeting. Thank you.
Thank you. I appreciate it.
And also, so we've had a little bit of change on the agenda for times. Jennifer Strohacker needs to jump off early, so we're going to go to her agenda items next. And then we can go back to Colby and Jim. So if we want to jump there, Rachel, if you want to introduce that.
Happily. Okay. Director Strohacker, if you want to take it away and do your update.
Yeah, thank you, Rachel. Hello, everyone. Hope you're having a good week and month. Have a few updates we'd like to share on the Medicaid side. So I have two different pieces that I was asked to present. And the one item, I'll just put them together, my director's report, as well as an update on HR1 timelines. So specifically, I know we've been visiting the HR1 or the One Big Beautiful Bill impacts over the last many meetings and walking through the final bill language and those different requirements and what they will mean to our program. An item that I was asked to present on today was to review with you a timeline of these changes. I think one piece that's important to note is while this was a very, very large and expansive bill that contained more than 21 Medicaid provisions, within that, it's important to note that these do have delayed and staggered timelines for many of them. And so I wanted to just walk through that today, and we will distribute this and soon be posting this on our public webpage that we're putting together for HR1 impacts. But wanted to just present this to you today. So when the bill was signed into law in July, it did require specific things immediately upon the signature of the bill and moving into law. And what you'll see here is, first of all, is that eligibility and enrollment rule moratorium. So there were impacts with the Biden administration putting forth the eligibility rule, which had many things that already did actually go into place, but there were certain aspects of that bill that needed to be implemented at a future date. And within that, there were certain provisions that became optional and others that were actually put on complete hold until 2034. And so that went into effect immediately, that states could not implement certain aspects of the Biden era eligibility rule that was out there. Now, note that as a state, we had a whole project plan around the eligibility rule. Many of those pieces of the eligibility rule have already been put into a place, but there were some items that we, of course, have not implemented yet. And then there are specific items that we are not allowed to implement. And so speaking to one of those, because as you may be looking at different pieces of of this bill and what that means. One piece of the eligibility rule that we are not able to implement were, and I'm going to need Michelle's help here, but extensions on some timelines for applicants who were submitting their information to us when they were submitting a Medicaid application. There is a period of time of 30 days that they're able to submit their documentation to us. And if we have additional pieces that we need, that we have given, there's a specified window of time. And I know, Melissa, I saw you on the call. So Melissa, you can speak to this. Thanks, Michelle. What the eligibility rule had done is it had extended that window so that Medicaid members had additional time to submit requested paperwork that would help validate and verify their application. And that extended window that was proposed as part of the eligibility rule, we are not allowed to implement that piece. And so wanted to just take a moment of time to talk about that with you because that I'm not, and maybe Michelle, you can come on camera, or Melissa, that I think specifically also is where we had impacts both with children and adults with that extended verification window. And when you hear and see that there are enrollment impacts due to HR1, there are specific, this is a lot of the enrollment impacts, of course, are really focused on adult expansion, but this one provision here and the moratorium on implementing this specifically could impact, an opportunity that could have been realized by all Medicaid members. And so I wanted to point that out and just call attention to that. And other things too, you're aware of a prohibition of payments that came about with different federal payments. Called out here specifically are those with Planned Parenthood was put into place at that time. And then also what's important around hospitals and provider tax provisions is that those were frozen. So Utah has a hospital state-directed payment and provider taxes on our hospitals as well as our nursing homes, intermediate care facilities, and our ambulances. And these provisions applied specifically to our hospitals and our emergency transport tax, that those limits and where they are at now are frozen, and you are not able to create new taxes or change the limit or threshold that you are at. So you're frozen at that point. Also in 2025, you're going to see that the Rural Health Transformation and Rural Health Fund was put into effect. So I'll have Dr. Iqbal walk through that here in the future. So I won't spend any time, but that she'll be covering that later in the meeting. But these pieces were also put in place. Now we go ahead almost a year and a few months. So October of 2026, we're going to see our first significant policy changes that individuals will begin to realize. And this is around some eligibility changes for immigrants. And with this, it also changes some of the eligibility categories today that are permitted underneath the Medicaid program, and it narrows those down so that there are fewer eligibility categories for immigrant populations that today are authorized to qualify and receive services through the Medicaid program. There was some data released this week through our legislative fiscal analyst that did evaluate and project some numbers associated with this. And we have reported that it would affect approximately, based off our assessments today and who's enrolled in these programs today, approximately 5,600 individuals who are receiving coverage today would potentially lose their coverage. But our task is then to see if these individuals could receive coverage through different Medicaid programs in the future. But today, those are some estimated impacts. So if you're looking at those changes, there's still some additional questions that we have about this and many other provisions. And CMS has said that they will not be responding or providing any guidance to our questions until much later this year. And so we are kind of sitting on hold. Note with any of the estimated impacts, and whether that be on enrollment and with our financial impacts, that many of these could be subject to change because there are still a lot of unknowns. And when we're creating estimates of impact, we're doing them with, based off of our existing knowledge today and without clear direction in some policy areas. Moving on to another change in October of 2026, there is also at that point implementation of for our emergency Medicaid group. And our emergency Medicaid group today, more than 5,000 individuals annually receive an emergency Medicaid benefit. This is a federally authorized benefit for non-citizens to receive Medicaid coverage for a limited group of services that are emergent and qualify as emergent conditions. And within this approved coverage group, they will take the 90/10 match, which we receive for our adult expansion members who would otherwise qualify for adult expansion, that would be within that group. And we have a reduced FMAP down to our standard FMAP for that group. I'll note that our interpretation of this with our legal counsel and our own department do not believe that this does trigger our trigger law because it is not a traditional Medicaid group. It's a limited group, but wanted to just note that we do not believe it triggers our trigger law. And that and it shouldn't change their coverage of services either. So these people would still be eligible. We'll just have to pay a standard FMAP for them. Okay, moving into January of 2027, this is where we're going to see the bulk of change happening that you will see from an enrollment perspective. And as you know, we've talked about this multiple times. This is when our adult expansion population and also putting TAM into that group will begin to experience and be required to complete community engagement activities as a requirement to Medicaid enrollment. So again, what this means is that prior to even applying for Medicaid or being approved for Medicaid, an individual is required to satisfy 80 hours of work, community service, or educational activities in order to meet the standard for Medicaid and then to apply for the Medicaid adult expansion benefit. In addition to this, there are numerous exemptions that have been noted so that of the population, for those who may meet an exemption, you don't have to meet those 80 hours of community engagement requirements, that you could be exempt from those through and exempt, one of these exempted processes or exempted categories. And so those will go into effect on January 1. Additionally, on January 1 of 2027, it will initiate the 6-month review cycle for individuals in that adult expansion / TAM category, so that you'll see more frequent eligibility reviews for that group. Just to note as well is that when there are 6-month eligibility reviews, the eligibility reviews really, while they will occur every 6 months, the TAM continuous eligibility that we currently have, where we have an approval for 12 months continuous enrollment for our TAM population, that will terminate when this goes live, in the sense that we will not receive renewal from CMS for continuous enrollment of our TAM population. And so that authority will expire in July of 2027. And so TAM and adult expansion will both be subject to 6-month reviews. And so I wanted to just bring that note to point today, just specifically because today we have approval for 12 months continuous, but that will go away in the future. Not only that, the DWS and DHHS are required to implement activities that will strengthen our oversight and monitoring of duplicate enrollment and address verification. There are several things we are doing today to satisfy these requirements, but we will be layering on additional activities, and there will be things on the federal level where we are required to meet up with some systems that are being designed on the federal side to satisfy these requirements, making sure that individuals, and we are monitoring and ensuring people are not enrolled in Utah Medicaid and in another state Medicaid program concurrently, as well as other programs, and that we are verifying addresses as a component of that. Additionally, there is going to be greater scrutiny put on budget neutrality calculations and how states are not just calculating, but utilizing their budget neutrality and calculating their estimates, and also performing with regard to their 1115 waivers and budget neutrality. We have a lot more questions on this one we'd like to walk through with our federal partners, but we know that there are kind of stricter standards and more evaluation of our budget neutrality estimates and calculation. In 2028, there are additional requirements to ensure that the individuals who are enrolled in the Medicaid program that are truly on the program, that we are paying for services of individuals. Again, we have already processes and procedures in place to identify individuals who may have deceased, to have been on the program. But this is just some layers that were included in the law that we will ensure compliance with. Additionally, ensuring that providers, we already have service processes in place to scan for providers who may have been deceased and no longer are providing services, but ensuring that our systems capture that and are compliant with that. In addition to some new limits put in place around an individual's assets and looking at Medicaid eligibility around a home equity limit. And then you see some additional things here too with regard to HCBS waiver options. There's been some expansion offered around what a state could apply for with regard to a home and community-based service waiver, and that they are expanding the kind of the allowable options for states in pursuing waivers. Also in October of that year, we see some changes around adult expansion, cost sharing requirements. And in fact, Utah is already applying cost sharing standards to our adult expansion population. So we see just a small change around cost sharing and emergency room visits actually going down for our Medicaid enrollees here. And then, of course, in October of 2029, we have additional provisions around duplicate enrollment and erroneous payments. So we will post this to our website, but I will take any questions you may have, and I have some staff on the line who can help as well if there are additional questions about this timeline or any additional questions you may have. Still pretty preliminary from where we were last month. We're still, waiting for further direction from our federal partners. Okay, great. Thank you. Couple things I'd like to just wrap up this section on with regard to updates with HR1 is that we have named Michelle Smith as our project director for HR1 projects. We see this as a several year project where it will require project planning, project oversight, all the way through implementation and ongoing monitoring. And so Michelle Smith, if you can just come off mute for a quick second so you can come on camera here. I can't see you as one of my panels right now, but many of you know Michelle. She presents to us monthly as the director from our eligibility policy area, but she will be leaving her director of eligibility policy area role to assume this role as our project director for our HR1 HR1 activities. And so I wanted to just make that announcement today. We are also recruiting a full-time staff member who will be assisting Michelle in this work. And so I wanted to say that we don't yet have a recruitment posted, but we will be posting a position for this, as well as doing just an internal recruitment for the Director of Eligibility Policy position, which we will backfill while Michelle is in her role as project director for HR1. So I wanted to just make that announcement today. You will see her leading out on many things in the future. Michelle is seasoned in this area and has led many large projects for us over the years. And we're confident she's going to do a great job with this, but recognizing we need to commit staff and dedicate their time exclusively to this work to ensure that we can do the best we can for coordination with all of you and on behalf of our members. And that's our commitment moving forward. With that, also want to state that in the upcoming weeks, we will be putting up a website, a formal web page with links to resources and announcements and other things regarding HR1 and the many different provisions we covered here, but also the different information as we have it. It can serve as a dashboard and many other things. And so we want to make sure that our work is public facing and accessible to you. So a document like this that I went through today can be posted on our website, and you all can access that and go there as a landing page for all this work, maybe as a first stop. So you don't have to wait month to month until we hear from you. You hear from us anyway. So wanted to let you know about that. Additionally, Colby will be presenting shortly, but Colby and Michelle have been hard at work in developing outreach materials for our providers and also our members. They have many questions, and also we want them to understand how all of this work may impact them, and also how they can get involved in helping and or supporting the activities. So we will be adding provider and member resources to that page as well, and then likely holding stakeholder work groups as we really move forward on community engagement and other things. We're going to need input in building this properly and in a way that can best serve our members and reduce the member impact as individuals navigate these changes. So I don't know, Michelle, if there's any additional thoughts you may have at this time.
Yeah, no, thanks, Jen. I look forward to helping lead out on this. And like Jen had mentioned, we're working really hard to get the webpage up with Colby. And so more to come, definitely. But I think you covered all the pressing things today. Thanks, Jen.
Yeah, thank you, Michelle. Okay, I'm going to pivot now and just do a few division updates. Oh, go ahead, Thais.
Hey, Jen, I'm sorry. I just had a quick question. Going back to the retroactive eligibility changes, will this also impact the emergency Medicaid group as well?
Oh, interesting. You're retroactive eligibility. Now that you're saying that, I'm like, I don't remember seeing that here on my list. We may have left that off. Go ahead, Michelle.
Yeah, no, absolutely. So it's on the list, Jen, but in terms
I didn't
of
mention it. I'm sorry. I didn't mention
okay.
it. Yeah, there it is. Reduction of retroactive period. My apologies.
Yeah, no worries. I think that's a really great question, Thais. The retroactive period for emergency Medicaid individuals, we still tie it to a regular Medicaid category. So if I'm looking at adult expansion emergency Medicaid, then I follow those rules, right? So for adult expansion, the change will be from 3 months to 1 month. And for all other Medicaid categories, it will go to 2 months. So
Gotcha.
hopefully that helps.
Yeah, that's very helpful. Thank you so much. Appreciate it.
I apologize. I overlooked that. Thank you. Okay, let me just give a couple of other updates. So on good front with regard to moving forward with offering services for individuals who qualify for them. Wanted to announce that we have officially awarded our contracts for our medical respite program. So we've been talking about medical respite for some time. This was officially approved underneath our health-related social needs waiver that we had approved from CMS last year, at the end of last year, early this year sometime. And with that, what that does is that allows an individual who's enrolled in adult expansion or TAM, who is moving out of a hospital or nursing home facility, who also requires a home health level of care and would otherwise be discharged to a housing unstable or a homeless status, to receive medical respite services for up to 60 days annually at a qualifying facility. We had limited, the procurement for this allowed us to solicit 2 different sites for this program at this time. And the 2 contracts have been awarded to the 4th Street and also the In-Between. And so with that, that we are in the contract negotiation phases with both of these partners that we have. And we hope to be able to begin offering services in early fall. We're saying hopefully October timeframe. Contract negotiations could go faster or a little bit longer. So, but we're targeting an October 1 date. And so we know this is a really valuable service to individuals. These are both great partners to our program, and we're really thankful that we're able to have them really launch this new service for us, but wanted to let you know about that. Okay, couple other things I wanted to share as announcements, if I could, is an update that we received today regarding our non-emergency transportation vendor, MotiveCare. And I'm going to put a link into the chat just so you're aware of what we received. So MotiveCare is our non-emergency medical transportation provider for individuals who are living outside of the Wasatch Front, who may not be able to access TRAX or our bus system, or we have also some IHS providers as well, but MotiveCare really is our Medicaid NEMT provider. They provide about 20,000 transports per month for Medicaid enrollees. And what I wanted to share with you now is that they have notified us that they are declaring bankruptcy and that they will be doing a financial restructure. The official notice is in the chat if you'd like to see it. That's what we received from their press release. They do assure us that all of their service lines will continue to operate in an ordinary manner, and they do not expect to interrupt or change service to our Medicaid clients that they serve. And so I'll say that we have a scheduled meeting this afternoon to meet with MotiveCare and talk through this email that we received and really make sure that we are very in touch with these changes. And what MotiveCare does is they contract often with subcontractors to be able to do their work. And so we want to ensure there is continuity of care with this announcement, and that members are still getting access to services in the ways that they need. We have information that we will be putting together briefly and have been able to assemble for our customer service line, some talking points, as well as being shared with our managed care partners as they may be getting calls as well as this news gets released to ensure that Medicaid members are able to get the right information. So we're working with that. Colby's on this call, so she's going to be helping us draft some talking points. But again, we will we will be meeting with them this afternoon and have more information. This is really just a fresh announcement, but I wanted to share it in this setting because many of you are interfacing with Medicaid members or part of at least the continuum of care. And if you're hearing things or have questions, we would invite you to send those to us. And currently, Nelson, we have them, as of their July report, they offered more than 19,000 rides that month. So one member may get multiple rides, but they did have more than 19,000 transits in the month of July. So many, many people, thousands of people rely on ModivCare for this. And so we appreciate that you may be getting questions or calls. We don't have all the answers right now. We have a notification, and we have not met with the vendor yet, but we will be later today. And so more information will be coming. And Colby, is there anything you'd like to add to that?
No, I don't. This is fresh news for us, and so we are just trying to get a better understanding, wrap our brains around how this impact will affect our members, and get a game plan moving forward. So I thank you for sharing what we know at this point, Jen.
Yep, thank you, Colby. Okay, more to come. Next item I'd like to share is another kind of a newer update for our program, but wanted to share today what we know. We learned earlier this week from our federal partner, CMS, that they are launching a directive to verify citizenship and immigration status for both Medicaid and CHIP. And I'm going to give you just a very high level of this because this is something that is still, like I said, a new announcement. And we can, I believe they do have a release we could put in the chat. Colby, do you mind if you have access to that, just putting it so you can read a little bit more about this? But every month, our Medicaid program does send information to our federal partners through a program. This data exchange is called TMSIS. And through TMSIS reporting, we send millions of pieces of Medicaid data. And some of that is citizenship data as part of their eligibility review and application. And under this, what CMS is doing is on their side, they are performing reviews of all states' TMSIS data, looking at citizenship and immigration status for all states on a monthly basis and evaluating those those data pieces. What they are also doing is we've been told that a monthly report will be sent to each state with a list of enrollees whose status could not be verified. And so this file will be sent directly to the state Medicaid director, myself, and with who then I will distribute it internally and to our DWS partners. And we will then be required to review that data. We have been told, as you will see in this CMS news brief, that the data is approximately 2 to 3 months old that we receive. But when they kick off this process, the objective is that they will be doing this on a monthly basis. So this will be ongoing for us. So once a month, we will be receiving something like this. And that our job is to review that report and to confirm or evaluate the data that is sent to us. This is still new. Our teams just received this notice and are working through a process by which we will perform these reviews. And we are then required to send the outcome of that report and that review back to our federal partners and also work with individuals. And so I don't know, Michelle, if there's more information that you and Melissa would like to share at this time, or go ahead.
Yeah, I think you covered it really well, Jen. I think more to come once we get the list and we're able to go through that and do some analysis and see what is sent over and what action is necessary. I think we'll have some more information to share. And then also in that letter, CMS offered that they will be sending further guidance on what the reporting from states looks like, and that mechanism. So more to come, I think, in the near
Yep.
future on that.
Thank you. Go ahead, Rachel.
So I know that this is probably going to take up a lot of your time and of what you don't have right now. That being said, if there's any way that you could report out to us on the number of cases
I think we lost Rachel. Yeah, when she comes back, we'll sync back up with her. It sounds like she wants us to report out on what we see. The update I'd like to share, and the last piece of this, is that Utah does expect to receive a report this week. And so we will have information that we'll have to review. But wanted to let you know, I think we, again, are just receiving this information this week as far as the CMS directive, and we are working internally to evaluate a process and evaluate the information and develop a process. And so wanted to let you know the status of that. It's still very early on. We can bring more information back in the future, but wanted to let you know about this process starting off. Go ahead, Rachel. Sorry, we lost you.
Sorry, I don't know what's wrong with my apartment at this point. Anyway, so I know you guys have a lot on your plate, but if there's any way that you guys could let us know on like maybe every MAC meeting, I'm not going to ask for another data point on like your eligibility check board, because I feel like that's a lot to ask right now. But like, if you could let us know generally how many cases you guys are having to review, I think that would be helpful to us to know how many people are subject to this kind of like re-verification process. If you could do that, it would really, I think it would help us too. And if there's anything I'm speaking for like the enrollment assisters at the health centers can do to help in this process, please let us know. I don't know if anyone else like has contact with enrollment assisters, but if there's anything that enrollment assisters can do to help with this process, I think just let us know.
Yeah, thank you. Yeah, we'd be happy to add that to the report. And, Michelle, one thing I do think that is important for us just to level set with you, so we're all at least on the same page as we start this and have been asked to do this activity. Michelle, would you walk through today, just so everyone on the call is very clear, the process that a person, as they apply for Medicaid today, that field of citizenship status, like, can you just like walk through the process so everyone is just aware of the intake?
Yeah, no, absolutely, Jen. So today, when someone applies for Medicaid, Medicaid or CHIP, depending on if they've been a previous member or new member, you kind of go down a couple of different paths. But on the application, some of you on this call are probably familiar. We do gather some initial information on the individual in terms of their citizenship status. So they make an attestation of their citizenship, whether they are a U.S. citizen or lawfully residing, and they mark that on the application. If they do declare or self-attest to being a U.S. citizen, on Department of Workforce Service side, we do our data check where we look to see, interface with Social Security to validate that citizenship. It's roughly over 90% of individuals where we are able to validate through that system check. For the individuals that we are not able to validate through that, we send out a notice and we give a 90-day reasonable opportunity period. And we give a list of paperwork or verification that someone can bring in to validate their citizenship. So they have 90 days to do that if they're declaring that they are a citizen. So that's the process for people who are a U.S. citizen. If someone is claiming that they are, a qualified immigrant and have a status, we also have a data check that we run on our side. And we can gather that information typically through that process. And if not, we do the same thing. We will send out information requesting them to provide, verification or paperwork to show that qualified status. So That is kind of in a nutshell the process. Now, if that individual has previously been on Medicaid and we already have that validation in place, we do not need to do that revalidation. So that's an important note as well. If Gina or Melissa, if I've missed something, please feel free to speak up. But I think in simple terms, Jen, that kind of covers the process. So
Thank you, Michelle.
Yeah.
Do the attendees have any questions about this? We want to make sure you understand the process by which that information is collected today and how individuals are, are just filling out the forms and being able to report that. And then, anyway, we can present further steps of the process we're taking when we get the evaluation, but I wanted to lay that out today. So the revalidation part, what is going to change?
I think that's the part that we're a bit unclear on. I think that's a really good question, Zuriak. And I think once we get that report that Jen mentioned and we're able to go through that to kind of see who they're sending us and what's going on, we'll have some more information for Jen to share.
Thank you.
And with that, wraps up my time for presentation. Thank you.
Does anyone have any questions for Director Strohacker? Okay, hearing none. I think we can move on to the next agenda item, which will be, and Sharon, correct me if I'm wrong, because I know that there's been some movement, will be the back update from Colby.
Yes, so just as a reminder, the BAC is the Beneficiary Advisory Council. The first meeting was in June of this year. We just had our second meeting on the 14th of August. It's a collaboration between members or parents or guardians of members who are willing to provide us feedback and improvement ideas and give us more of a lived experience of the member as they navigate the system and the program. And so as we already recapped the June meeting, so I will be brief in my recap of the August meeting. There were some concerns, obviously, regarding the One Big Beautiful Bill Act, wanting to better understand how this will impact their family specifically and others within their community. And I think specifically the disability community is one of great concern. And so we were able to talk through some of the things that Jen spoke about today, but we'll be providing them with ongoing information so that they can help inform their communities in which they're advocates for. Additionally, they wanted to understand the work requirement and our 1115 waiver submission. And so we were able to discuss that a bit. They do have concerns about the rural population and their access to care. And then another issue that came up was helping members meet their timelines or deadlines for submitting paperwork, and especially considering the recertification every 6 months instead of 12 months for some programs. With the One Big Beautiful Bill Act. So I think that is top of mind for most participants on this council right now. And we're, with each quarterly meeting, we'll be providing more information for them, reporting back on issues or topics that they brought up, and also providing solutions or ideas for solutions that we may have with issues that they've brought to the table. Are there any questions? Great question. How, can't see it all. To apply for open seats. Yes, we are always recruiting. There is information on our website, so I can post that here in the chat, where anyone that's interested in becoming a BAC member can, get the information from Sharon. It is a closed meeting, so they will need to let us know in advance if they'd like to participate, but we are always, thank you, Sharon. We are always, seeking more participation. And in this meeting specifically, we had a couple more people that didn't participate in the first meeting. We're hoping to just continue to build and grow. Anything else? I think that's all. Thank you, Rachel.
Thank you, Colby. And then, sorry, my computer is still frozen. We'll move on to, number 4 is our adult dental waiver utilization review from Jim Stamos.
Hi, everyone. Sharon, is it okay if I share my screen? I had prepared some slides. Perfect. Thank you very much. So I was asked to give an update on our dental expansion, and I have prepared just some data to review with everybody. So first off, I just want to note that this is using claims data that began in April 2025. So providers have a year to submit data. So I would say that this data is probably not complete, but it should at least give us an idea of the impact and changes that adult dental expansion has had. So approximately 9,500 individuals, or about 11% of newly eligible adults have accessed services since go live. So that's quite a bit of individuals who have accessed this service since just in the little over, I guess, 4 months about since this went live. This data is looking at just those people who are newly eligible, and that's just an important thing to look at as we're discussing this. Our first slide, we broke it down by age to give you an idea of the number of people who are accessing the dental services by age group. So you can see the highest group is 30 and 40s. 60 and above is the lowest age group that has accessed it. However, if we do look at it by percentage wise, so this is percentage of those eligible. So I'm just going to make up some numbers here, but let's just say, there were 1,000 20-year-olds that newly had access to it, then 10% of those people have access. So you can see it's pretty even when we look at it by percentage, that we're getting about 10% by each category is accessing dental services. So it's being evenly spread across all age groups. As far as where people are accessing it, we're getting the highest utilization here in Emery County and Carbon. So you'd say about 20% of those people who are newly eligible who live in Emery County are accessing the dental program. San Juan County is our lowest county, just to kind of point out some of the discrepancies. But again, if we look at it as a whole, you can see that most people around the state are accessing dental services. And then what type of services are being being billed for is diagnostic services is the largest. So we took the claims and we kind of just grouped them into categories from the codes that they were doing. So you can see about 45% of the claims probably had to do with codes regarding diagnostic services. Next most was restorative procedures like fillings and crowns. So you can see that people are going in and then they get a diagnostic, and then they're going to get their crown filled. The next highest would be extractions, tooth extractions, or other surgeries that are going. So those are the types of procedures that are being received by the members. As far as just some takeaways, so we have seen a large increase in utilization for dental services for adults, which is good. We're getting access from all areas of the state, which is pretty positive. And all age groups, are accessing the services. So all those things are positive takeaways with the dental expansion program. Those are the slides I had prepared. Is there any questions anyone had about dental adult expansion? Okay, great. Well, Sharon, if there are any other questions, please email me. I'm happy to work through them.
Thank you, Jim. I appreciate it, especially because that was my request.
Perfect.
Let me see. I like my computer's back on, but I do not have my agenda in front of me. So if you want to give me a hint, Sharon, on which ones. Okay, there we go. Oh, perfect. Number 5, we're going to move on to an overview of the Rural Health Transformation Fund project from Dr. Iqbal.
Thank you. Sharon, is it okay if I share my screen as well? I have some slides presented. Please let me know if you're able to see my screen.
We can see it.
Thank you so much. Thank you for the opportunity. My name is Ronak Iqbal. I'm the Medicaid Medical Director in the Department of Health and Human Service. I was asked to update about the Rural Health Transformation Program. As you know, in July 4th of 2025, President Trump did sign the One Big Beautiful Act into law. In addition to the wide range of federal tax policies modifications, the legislation also included significant changes to Medicaid and related health care programs. To mitigate some of the potential adverse impact, Congress allotted about $50 billion to establish the Rural Health Transformation Fund under the H.R. 1 bill. This 5-year program is designed to strengthen the healthcare access, infrastructure, and workforce development in the rural communities. And this fund is basically divided into 2 big buckets of $25 billion each, with the first bucket distributed equally among the 50 states. U.S. territories and District of Columbia are excluded from this funding. Upon approval of its application, Utah is projected to receive at least $100 million annually between the fiscal year 2006 to the fiscal year 2023. While this does represent a very significant investment, it does fall short of offsetting the broader healthcare cuts, which are far greater in scope. Also, we have to understand that this funding is a one-time funding, while the reduction in Medicaid is permanent and expected to go through the budget window and beyond. Now, the other $25 billion, which you see over here, that is a slightly difficult bucket to understand. The CMS administrator will decide how the distribution of these resources are based, and it will be based on, number 1, the rural population of the state, the percentage of each state's population residing in rural area. Sadly, Utah is actually not scoring very well on this category. We are ranked the 7th least rural state in the nation. The second point is rural health facilities. The state proportion of rural health facilities is relative to the national total. And this criteria is difficult to evaluate given the broad definition of the rural health facilities in the bill and the lack of comprehensive nationwide data availability. And the next issue for this is the hospitals serving these low-income patient population. And as you know, the financial status of hospitals that disproportionately serve the low-income patient with special needs, as of 2021, 31 of the 40 Utah disproportionate share hospitals already receive more Medicaid funding than the total cost of their uncompensated care. And lastly, any additional factor that the CMS administrator might feel is deemed necessary. So given this criteria, it remains uncertain whether the Utah will secure funding for the second bucket, but we do know that we qualify for the first bucket. In order to be eligible, the state must submit a rural health transformation plan to the Center for Medicaid and Medicaid Services by December 31st. However, the guidelines also state that the CMS will approve or deny the application on the same date. So that means that effectively the deadline for submission has to be quite earlier. Now, when we need to submit our application, we have to focus at least 3 of the following 9 activities. I'm not going to read all of the slide, but I'll just highlight a few important ones. So the options available to us is either an evidence-based measurable intervention for preventing chronic disease management,
direct payment to providers for healthcare and item services, technology-driven solutions for chronic disease prevention and management, training and technical assistance in advocating technologies like AI or remote telehealth monitoring, recruitment and retention of clinical workforce with the rural service community, IT upgrade for efficiency and cybersecurity, right-sizing healthcare delivery system in the rural area. It could be an opioid or a substance use disorder or a mental health treatment program service. And then lastly, it could be innovative care model like value-based care or alternate pay model. So on August 13th, the Department of Health and Human Services started the conversation with an informal webinar. At the closure of the session, we shared the Rural Health Transformation website, which I'm happy to put in the text as well, which included a link for a stakeholder survey. And I'm really happy to share with you that as of this site's existence, we received 370 views from 213 individual visitors, and to date, 66 stakeholders have completed the survey. The survey is expected to remain open until the midnight of Friday the 22nd. And then I want to let you know that Dr. Oz also stated that the Rural Health Funding Program will be released, the CMS application process will be released sometime in early September. And so this will give us a very tight window period. We're thinking 6 weeks to 8 weeks to actually submit our application process. And once these guidelines are made available, we plan to have listening sessions all across the state of Utah. So we are hoping to get one session in the central, one in the north, and one in the south. We are thinking maybe, and this is not set in stone yet, but Brigham City, Moab City, and Cedar City to ensure that the local officials and communities can actively engage in the process. And we want to get insight and feedback from these work groups to see where do these rural communities identify issues that we can help focus on. Lastly, after we've done these stakeholders, committees, and sessions, we will start to make the CMS application guidelines. And for that, we will sometime in October, November, have our GOP review them. We'll have the internal DHS reviewers as well. And then once everybody has agreed to the application process, we will submit the application. By December 31st, CMS will either approve or deny our application. And then after that, we will start the hard work of distributing the funds. In order for us to not miss any concerns or issues that may be brought forward from the stakeholders, we have this special website, or I should say email address for rural ht@utah.gov, where anybody who has concerns, questions can put their information. And in the chat, I am going to put in the link to our rural health website as well. If anybody has any questions, I'm happy to answer them now.
Okay, hearing no. Yeah, thank you, Dr. Iqbal.
Thank you.
We appreciate that. And I'm so sorry, not prepared. Thank you. So we'll move on to number 6 with our eligibility enrollment update from Michelle.
Yeah, thanks, Rachel. Hi, everybody. I'll go ahead and present the dashboard. 1 second. Great. Can everybody see that okay?
I can see it.
Great. Awesome. Okay. All right. So the July enrollment total population currently for July is 350,411 individuals. When you go over to the data table, which drills down into the different coverage groups, I looked through these as I always do. I didn't see any significant changes with enrollment. But again, this is available on our website. For those of you who are not familiar with that, I'll go ahead and drop it in the chat so that you guys can access that, and you can go into any of the detail that I will not go through today. You're welcome to do that. And if you have any questions, please feel free to reach out. I'll mention as well, we currently have a state CHIP program open for enrollment, and the current enrollment for state CHIP as of the first of this week was 1,489 children enrolled on the state CHIP program. That is still open for enrollment. I will go over to our eligibility data dashboard. I'll also drop this in the chat. This is available as well on our website and is updated monthly with information and outcomes on eligibility. I'll focus just on this first tab. So again, for those of you who may not be familiar, there's different tabs at the top that you can look at different data. I'll just focus on the review outcomes. We're still doing very well on our ex parte efforts. We're roughly at 40% completion of ex parte, which means those are individuals that we're able to complete without any participation from the member. So that's been our goal, and we're still doing really well there. I'll switch over to the waiver data dashboard. This was something that was created out of this group as well. I'll drop this in the chat. This gets updated every single month as well with new data. I won't go into detail. A lot of this same eligibility information is on the main enrollment tab, but there is the benefit. So if you look at the top, if you haven't gone into this or are not familiar with it, you can toggle over to benefits that are under our 1115 waiver and look at enrollment under the benefits and scroll down. So I will pause there and just ask if there's anything that anybody wants me to look at or talk about or has any questions.
Michelle, this isn't like necessarily about eligibility and enrollment, or I guess it kind of is, but I maybe should have asked this earlier during the director's report, but can you let us know about any communication efforts around the data sharing between CMS and ICE? Like that you guys have communicated to members or anything maybe the federal government has said to them?
Yeah, I just saw Jen come on camera. Jen, if you want to answer that.
Yeah, thanks for the question, Rachel. We actually don't have any additional information about that news release that we shared with you about. We also ourselves put out a statement, which is on our website, about that news release that shared that CMS had opened some of its data sites to ICE to be able to review some eligibility data for Medicaid members. I think they have access to limited areas of that data through business hours. So ICE officials or Homeland Security officials have to go into themselves. They weren't given data sets. They would have to go in and look at them themselves. And then they had to do it during regular business hours up through, I believe, September 5th was the time frame that they could do that evaluation. Brian did include the link to that notice in the chat, but we have no information since that has been noticed. We have no information about if anything's been done with it or any feedback from other states either. So we don't have anything to share beyond what we received with regard to notification.
Thank you. I appreciate that. Let us know if you hear anything. I know a lot of us are waiting on like a lot of information right now. So thank you.
Yeah, understood. Thank you.
Does anyone else have any eligibility enrollment questions for Michelle based on the current report or any questions? Hearing none, I think that brings us to our end. I know we had some switching around. Am I missing anything, Sharon?
You are not, except for the committee member updates is the last
Oh,
agenda
yep.
item. Yep.
Sorry. Does anyone have any updates to share with the group or any requests even?
Hey, this is Jennifer Brinton. I just want to say I'm really grateful that you guys have kept us in the loop about things happening with the federal changes, and I'm so grateful for the good things our state's been able to do, and just hoping we can keep Utah a good place to be and work on this together. So thank you.
Thank you, Dr. Britton. Anyone else have anything to add? Okay, hearing none. Our next meeting will be October 16th. It will still be from 2 to 4 p.m. But I expect to see a survey out or some type of communication out about good times to meet, because I do think that that's a conflict that probably causes some issues for some of our friends at the state. So with that, I think we are good to adjourn. Everyone have a good rest of your day, and we'll talk to you in October.
Thank you.
Thank you.